Hello, ladies and gentlemen, and welcome to this cardiovascular news roundtable dedicated to the discussion of dual antiplatelet therapy and drug-eluting stent. Is it time to change the guidelines? This is an ambitious topic and is dedicated to physicians to offer them an overview of the available evidence and to share with them the available new evidence from recent studies, and to spark a discussion on whether is it time to change these current guidelines. To do this, we have here a panel of distinguished colleagues, and it's a pleasure for me to introduce all of them. It's Dr. Alex Abisaid from the Instituto Dante Passanese in São Paulo, Brazil. Welcome, Alex, and thank you for coming.
Thank you, Flavio. My pleasure.
Dr. Asim Latib, who works at the Istituto San Raffaele in Milan, Italy.
Thanks, Flavio. Thanks for having me.
And Professor Sigmund Silbert from Munich, who works at the practice and hospital at the ISART in Munich. Thank you, Sigmund, for having me.
Thank you.
The first speaker of our roundtable is Dr. Abisaid, and he will give us an overview of the indications for dual antiplatelet therapy since the very beginning of the drug-eluting stent story.
Thank you, Flavio. So my task in this next 5 minutes is to review with you the past and present indication of dual antiplatelet therapy in the DS milieu. So if you remember, in the early days of DES, we prescribed 2 months for first-in-man when we treated patients with the Cypher stent, and 3 months dual antiplatelet therapy in Ravel and Sirius. With paclitaxel, 6 months was the former recommendation. So during that time, I would say in the early years of DES, the recommendation was 3 months for sirolimus and 6 months for paclitaxel. Then in 2006, we heard the results of the SCAR registry that raised some concerns in terms of late stent thrombosis, that the mortality would be higher with DS versus bare matter stents. So that was a little bit of a conflicting data that raised further discussion. More recently, the European and the US guidelines recommends as one evidence B that in the US, for instance, we should give dual antiplatelet therapy for 12 months. And the European guidelines says 6 to 12 months for patients receiving DES and stable angina, and 1 year for those patients with unstable angina. Is that with the current, more recent drug-eluting stents with more advanced technology in terms of lower polymer load, bioabsorbable polymer, thinner strut stents, that the trigger for stent thrombosis could be lower than the first generation DS.
Thank you, Alex, indeed, for this overview of the history of dual antiplatelet therapy. We start with a very short recommendation, even in the instructions for use. Then we have these statements of the scientific societies talking about 3 or 6 months. But then guidelines came out at 2010 for the European Society and 2011 for the Americans, and they recommend 1 year, 6 to 1 year.
Yeah, I agree. I think it was a fair statement based on to try and be safe. It wasn't based on a lot of data, though. I think it was based on 2 registry studies, not on randomized data. And I think it's worthwhile highlighting how the American guidelines and the European guidelines diverted, whereas the Americans almost came out with the American guidelines recommending 12 months as a minimum, whereas the European guidelines saying even 6 months might be okay in a lot of patients. But once again, reiterating what Alex said, it's first-generation drug-eluting stents. It may not apply today to the current second-generation drug-eluting stents, and that's why we're here today to discuss this.
Yeah, but let me go a little bit deeper into this guideline stuff. I mean, the first European guidelines came out 2005, and at that time we looked at the data, and there was not a single randomized trial with different duration of DAPT. So we decided 2005 to recommend at least 6 months, but this was only based on observational data. But 1 year later, as you know, the Barcelona firestorm came up. So the Americans became a little bit nervous and they jumped immediately from 6 months to 1 year, although there were absolutely no data until today to justify the at least 1 year recommendation. And today, which is 8 years after the first recommendation of the European Society of Cardiology came out, after 8 years, still we do not have data, I think, to justify to switch from the 6 to 12 month recommendation.
Yeah, I agree. I don't have much to add to that. I think we do that on a daily basis, all of us. And based on the more complex the patient is, the more complex the lesion or the number of drug-eluting stents we implant, certain lesions like bifurcations with 2 stents or overlapping stents, we feel more comfortable for our patients. I'm sometimes not sure whether we're treating our patients or ourselves when we do this, but we do it on a regular basis. But we do it because we're missing data that helps us with lesion selection. But I think we probably will continue doing it for a while until we have real good data that shows us that even in very complex lesions, shorter durations may be appropriate, as with simpler lesions. But we don't have that data for now.
Yes, well, to make it clear, guidelines are not a law. Guidelines are only recommendations. So in every guidelines, it's written that the patient first, and you have to make individual decisions. And of course, in complex lesions, bifurcations, and so on, we tend to go for a longer duration of dual antiplatelet therapy, but we still don't have the data. But let me just make one point for diabetic patients. We know that diabetes is a bad disease, and patients with diabetes have more complications. But with newer generation drug-eluting stents, and there are data out there, it could have been shown that diabetic patients are not at a higher risk than non-diabetic patients if you use one of those newer stents, unless they're not insulin dependent. Insulin dependent diabetics are a problem, but if they're not on insulin, I think their diabetic problem is much better solved today than it was about 5 years ago.
In terms of safety, what is more important for you, the stent or the technique of implantation?
Well, you look at me, so
You are the most expert. This is why my question goes to
well,
you.
of course, both is important. The stent is important, and I think the last slide Alexandre has shown is very important. These were preclinical data from Reno Vermani showing very, very clearly that not all drug-eluting stents are equal. They are different. And I just want to make a very important psychological remark. We should always keep in mind that the drug-eluting stent is not, let's say, a car. If a car has a problem, there are recall actions. If a heart valve has a problem, you can have a recall action, or even breast implants, as everybody knows, you can make recalls and take them out. But the stent is forever with the patient. So the decision which drug-eluting stent I use is really decisive for the rest of the patient's life. And we should make this decision very, very difficult. And so we have to know the data. There are some drug-eluting stents out there on the market. They don't have really data or only a few data. So we should really ask ourselves before we insert or implant a drug-eluting stent, would I, as the cardiologist, would I like to have this drug-eluting stent forever in my body, yes or no? And if I say yes, I would like to have it in my body, I think then we should implant it in the patient.
Good answer. So I think that we had a very nice discussion, and we can move to the next presentation.
Thank you, Flavio. It's a pleasure being here today. Well, in my presentation, really what I'd like to do is summarize some of the new randomized clinical data surrounding dual antiplatelet therapy and the duration of dual antiplatelet therapy, and a little bit highlight some of the difference between first and second generation drug-eluting stents. So the areas I'd really like to cover today are dual antiplatelet therapy and second generation drug-eluting stents, whether we should be thinking of prescribing in a different way to first generation drug-eluting stents, whether we need dual antiplatelet therapy for longer than 12 months, or whether 6 months actually is more than adequate. And let's look at the data. Carrying on longer than 12 months may actually be better. And I think this is a question we often face. I'm often faced with patients who come in at 12 months, they ask me should they stop, I ask them how are you feeling, and they go, I'm feeling great, I haven't had any bleeding. And you go, well, maybe you should just carry on. I think the current evidence suggests that dual antiplatelet therapy longer than 12 months is probably not needed and increases bleeding. For first generation drug-eluting stents, however, 12 months of dual antiplatelet therapy is still needed. 6 months may be more than sufficient for the second generation drug-eluting stents. But really what we need are more dedicated studies to look at shorter durations of dual antiplatelet therapy before we can think of changing the recommendations.
Okay, our next presentation will be given by Professor Silber from the Heart Center at the ISER in Munich, and he will provide us with more information about what can be the future of the duration of dual antiplatelet therapy.
Thank you, Flavio. After Alexandre talked about the past and Azim talked about the present, it is my task to talk about the future of dual antiplatelet therapy, especially the duration of dual antiplatelet therapy. We all know from clinical circumstances that there are situations where we have to discontinue the duration of dual antiplatelet therapy even before the lower limit of the recommendations of the guidelines. So the question is, what happens if this occurs? So overall, although it's a post-hoc analysis, I think the groups were rather good, comparable. Well, this is the first results, which is a very striking result. As you can see, as we knew from the previous studies presented, by interrupting dual antiplatelet therapy, this is the upper curve, within the first month after stent implantation is rather dangerous. You have a stent thrombosis rate of over 5%. But if you look at those patients who never interrupted and those patients who interrupted after 1 month, this is astounding. There is no difference in stent thrombosis rate, and even in those patients interrupting after 1 month, at least in these about 5,000 patients, we had a 0% stent thrombosis rate. Of course, this might be statistical coincidence, but it's very, very low.
So my question to you now is whether you find that the current guidelines are obsolete.
Do you want the short answer or the long answer?
The short
answer. I would say yes and no. Yes, the American guidelines are obsolete. No, the European guidelines are not obsolete. I mean, we have recommended at least 6 months, and Azim has shown the 3 randomized trials so far, which was 6 months versus 12 months, or 6 months versus 2 years, or 1 year versus 2 years. And all these 3 randomized trials have shown that longer dual antiplatelet therapy has no advantage for the patient, but we have no data on shorter. So I think the current recommendation from the ESC guidelines 2005 and 2010 are still valid.
Well, it's time for the conclusions. I would start saying that regardless of the type of intervention in the coronary level, we are treating patients, and most of these patients present with acute coronary syndromes. According to the current guidelines, these patients deserve 1 year dual antiplatelet therapy. The remaining 30% with a stable angina sometimes are not all good candidates for dual antiplatelet therapy, either because they need oral anticoagulation or because they are non-tolerant to aspirin or tyenopyridine. So in the end, the universe of patients that could indeed reduce this recommended 12 months is quite small. It's about 20% of our daily practice. So for patients presenting with acute coronary syndromes, the guidelines that we are following now remain current and will not change according to the type of stent. For second generation stents, we have, I would say, a full agreement on the fact that we can rely on 6 months rather than 12. Regarding a further reduction below 6 months, there is no enough evidence. We know that if it becomes necessary, we might rely on these second generation stents, but this is absolutely not a recommendation. So in the end, guidelines are still modern, are not obsolete. We can follow them, we can rely on them, and to change the current guidelines, we do need the results of the ongoing trials. Thank you very much.